Dr. Katie Smith is both a psychiatrist and a clinical academic at the University of Oxford. In the Department of Psychiatry, she specializes in mood disorders, but has done a lot of fascinating research across the mental health spectrum across her career. She's going to be discussing a paper, I'll put it in the chat right now, that everyone should have it there, that really discusses insights from a multidisciplinary consensus group that looked at some of the challenges, ethical considerations, and solutions in delivering digital mental health care, especially to populations of serious mental illness. So the paper that Dr. Smith is going to talk about really says, what does the evidence show for serious mental illness? Is it ready for clinical use? If so, can we use it? And what are some of the considerations? And what is the perspective of lived experience in these talks as well? So I'm going to hand it over to you, Dr. Smith.
Thank you so much, John, for the introduction. That's great. So I've just got a brief period of time, and I'm going to talk about a consensus meeting that we held and we published earlier this year in JMIR Mental Health. And as John said, it was focusing on digital mental health in the area of schizophrenia and severe mental illness. And we focus specifically not only on the challenges, there are many, but also on the potential solutions. So just before I dive into the paper, just a couple of acknowledgements for the support. For me, University of Oxford, I'm a member of the Oxford Precision Psychiatry Lab led by Professor Andrea Cipriani, and I'm also supported by the NIHR here in the UK. So this is the paper, and I think the link for this will go in the chat as well. I'm going to cover a small aspect of it today, but there's a lot more rich detail in there and a lot more examples if you're interested in looking at the original paper. So this was a consensus meeting, and you can see the team in the bottom right hand of the slide. Very much a team effort. All members contributed to the consensus and all were co-authors. So although I'm speaking to you today, it was very much the whole team who contributed to this. It was an international consensus. Very importantly, it was multidisciplinary. It's so important in digital mental health to have all perspectives. And we had patient and participant input, so PPI input at several levels. And I'll talk a little more about that when I'm going through the methods. So just very briefly, the issue and the problem area of severe mental illness, I think this will be familiar to most of you, but severe mental illness is taken to cover disorders such as schizophrenia, psychosis, and bipolar disorder. So perhaps the more severely impacting disorders that we see. We know that there are health inequalities. There's reduced life expectancy, somewhere between 10 or more years compared to the general population. And increasing access to care is an absolute priority. And that's where digital mental health interventions, perhaps those asynchronous interventions might be really helpful. But there is less research in the area of severe mental illness and digital health interventions. Not clear why this might be, but there are some quite widespread assumptions that people with severe mental illness might not be able, because of their symptoms, or willing to engage in interventions. And we also know about digital exclusion. So people with severe mental illness are excluded. And there are coexisting socioeconomic inequities, problems with digital literacy and confidence. Those have to some extent been addressed in some studies looking at promoting and training people to help with their literacy and confidence, but it's by no means widespread. So still an area of real need. So how did we reach a consensus? Well, we had this dilemma. It's a really broad, fast-moving, novel, innovative field. So we approached it by using a well-described method called the Consensus Development Panel Method. It was developed by the NIH and used by the NIH and WHO, World Health Organization, for this sort of innovative and novel area. So really well suited. And it involves a face-to-face meeting. We met over 2 days in late 2023 in Rome, Italy. It enables a multidisciplinary approach, as I said, so important for digital mental health interventions. It allows all members to contribute to the discussion. The decision-making process is transparent. And we focused on identifying challenges and potential solutions. But we were very aware that any consensus meeting is subject to bias. So we ensured that participants were international. We had patient and participant involvement. And we had, following the method, we had two groups within the consensus. We had experts who presented and a separate panel of clinicians and researchers who were less expert in digital mental health, who reflected that knowledge so that we can make a balanced decision. We had open questioning and debate. We also did a systematic literature review before the meeting and shared the results of that, and had a reflexivity statement in the paper to reflect on potential bias. So to the results. So we divided all the data, and it's very detailed, into four main themes. I'm going to focus on theme 1 today, which is engagement and attrition, but there are 3 more themes. Do look at the paper for more detail if you're interested. So theme 2 was around research methodology. Theme 3, thorny issues around regulation, governance and funding. And theme 4, the real issue of how you move from research settings to implementation in real-world clinical settings. So I'm focusing on theme 1 because of time, and it's a really, I think, important issue in digital mental health interventions around engagement and lack of engagement or attrition. So we know that engagement is absolutely key. However fantastic your digital mental health intervention, if the participant isn't engaged with it and has already abandoned it, it's not going to have an impact on outcome or symptoms. And we also know, familiar graph, I'm sure to many of you on the left-hand side from Baumel and colleagues, that although a lot of people upload, in this case apps, within days they're discarded and no longer used. There's also a difficulty in the research field in that there's a lack of consensus or standards about how we report in individual studies measurements of engagement. There are lots of different terms which you use, like usage, engagement, adherence, attrition, all apart from usage, which is objective, all are defined in different ways by different authors. And also the issue for severe mental illness that research in this area often focuses outside conditions, on conditions outside severe mental illness, and also outside an area of great need, which is lower and middle income countries. So this issue of engagement and attrition has led some authors, including Nuozo, which you can see on the right, wondering whether really engagement is one of the difficult areas in digital therapeutics and mental health. So we particularly looked at this area and thought in the consensus group about potential solutions, and there are some evidence out there for potential approaches to try and improve engagement. So one is to focus in development of the digital mental health intervention on participant-centered or human-centered design. So this goes beyond, if you like, the sort of light touch PPI involvement or tick box PPI involvement to a real integrated involvement. So this is where you have true representation of diverse populations. So not just the expert PPI member, but also purposive sampling to ensure that you're reaching those really hard to reach populations. It's also a method that involves both co-design, co-production and co-delivery. So PPI is involved throughout the design process, and it's integral within the study. And in a minute, I'll just highlight a couple of examples where that has been involved. And the face validity is very good. It makes complete sense to involve users in the development of a digital mental health intervention to make it more engaging. The second opportunity is to look at more personalized approaches, and you can do this on, I think, a couple of different levels. We talked in the consensus about developing the apps for a particular patient population, say for someone with a group with schizophrenia or a group with bipolar disorder, so that it's appropriate for that group. You can also involve personalization within the intervention to allow the participant to adapt the intervention to meet their own needs. And you can also think in a personalized way about which intervention is best for which particular patient. And this is where the organization of the clinic, perhaps the introduction of someone like a digital navigator, could really help the person to decide which app or digital mental health intervention is right for them. And finally, in severe mental illness, which often comes on in early adulthood, we need to look at early interventions. So I'll go through some of these options just briefly in the next couple of slides. So the first one is to look at this human-centered design, and I'm going to give a couple of examples of this. They're not the only examples, but these are the ones we highlighted in the paper. So the first one is slow-mo, and this is a digitally supported therapy for people who have symptoms of paranoia in the context of schizophrenia and schizophrenia spectrum psychosis. I won't touch on the details of the intervention. All the original papers are on the slide on the right. This comes from the group led by Philippa Garrity and colleagues in London. But what I wanted to highlight about this particular user-centered design is the amount of input that was involved in the development of this particular intervention. So during the whole life cycle of developing this, 8 hours per month on average were contributed by patients and participants. And this generated, as you can see, more than 100 recommended actions. So a huge amount of time and, in fact, funding is spent on this user-centered process. And the second example that I was going to give is of Game Change. This is a slightly different intervention. It's an automated virtual reality intervention, which is delivered for people with agoraphobic avoidance and distress in the context of psychosis. And again, the same sort of thing. You can see in total over 500 hours of input in the design process. So this study comes from the Oxford group, Daniel Freeman, and they involved patients and participants throughout the design process, but again, a really intensive thing to do. So I suppose that leaves us with those examples wondering whether this intensive input increases engagement and whether that increased engagement increases effectiveness. So in the two examples I gave you, slow-mo and Game Change, they certainly had some good engagement metrics, and the effectiveness was very positive, so that the NHS have now agreed to fund those while further evidence is gathered. But if you look at the literature, looking at the process of engagement and how that translates to effectiveness, there isn't very much research evidence. There's no mechanistic evidence looking at what's really required in engagement, which elements, or whether all of it is required. And so a lot more research there really to be done in terms of finding the essential elements. And finally, I just wanted to talk about interventions at the younger age. So I mentioned in terms of engagement and that severe mental illness often comes on in early adulthood. And you can see the graph on the left from Peter Ulas and colleagues just shows this in a very clever way, the different peaks of onset of different disorders. And you can see mood disorders and schizophrenia, severe mental illness, come on in early adulthood. So we need to be focusing our digital mental health interventions earlier in the prodromal phase, which would be in late childhood or adolescence. This seems to be a really good match. Many adolescents are very much engaged in digital media, and it meets, I think, the needs of social connectedness and novelty and adventure. But we need to ensure that our digital mental health interventions are appropriate for that age group. They're co-designed with young people in mind, and that they also meet the needs of the wider circle around the young person. So things like teachers, social workers, for example. Also, in the context of severe mental illness, we need to not forget the older adults. Severe mental illness tends to be a chronic disorder throughout the lifespan, and so any digital mental health intervention will need to cover that whole lifespan into older adults, which tend to have more digital exclusion. So in terms of take-home messages, our consensus methodology we felt was an effective way to focus directions in this very broad area and to help to sort of narrow the field and make recommendations for research and clinical implementation. We felt that we managed to integrate consensus formation with the current research evidence. We incorporated multidisciplinary international expertise. We also included patient and public participation. And we felt that this format of identifying challenges, but also potential solutions, was really key to helping to affect change. And for the first theme, we focused on engagement and attrition. And my final slide, for the engagement and attrition, as I said earlier, this focus on engagement is a key area for change. If we find that we can't engage people with our digital mental health interventions, then it's difficult to see a positive change in symptoms. There are difficulties with definitions around engagement, and so standardizing those, more transparent reporting in research studies would allow us to put together the evidence so that we could identify which elements are required for successful engagement. We need more mechanistic research and investigation of the different routes to improve engagement. And we need to not forget the clinician, because eventually the research evidence is going to move into the clinic. And so it's not just participant factors, it's also clinician factors, with ultimately the focus on outcomes, because that's what matters in terms of treating people with mental illness. So I'll stop there just at the 15 minutes and keep it open for questions.
Thank you so much, Dr. Smith. It's such a broad agenda you helped us outline just with theme one, right? There's more to do, but I think the points that you brought up really could, and I think may take up some of the careers of people listening on this webinar, because it's such an important question, right? What does engagement mean? How do we measure it? And what do we know it does? And I'll encourage anyone, you can put chats into the Q&A. I think one broad question I've seen come up is certainly for psychopharmacology, for medicines, we know if someone swallows the pill, likely most people have similar biology, there's differences, but the circulatory system gets the drug to the brain. And there's a whole issue of adherence in swallowing a pill. But for these digital mental health tools and apps, do you think there is going to be one? There is no circulatory system. We all live in different worlds. We live on one world, but we live in different areas. We have different patterns. We have different cultures. We use technology differently. Do you think there's a search for one kind of engagement pathway, or are we going to find perhaps that there's many different engagement pathways? It's a broad question, but in your work, any directions you think are more correct in that framing?
I think you're right. I think the concept of engagement is really complex, because it's not just about adhering or using a digital mental health intervention. And we sometimes regard people who drop out from an intervention as being negative. So they've stopped using an intervention because they don't like it or it's not meeting their needs. But it's a little bit more complex than that, because it may be that people stop using the intervention because they have improved, or because they've taken on board the learning that's within the intervention and they're using it outside the intervention. So they've taken on board some of the strategies, for dealing with situations. Maybe they've practiced in virtual reality and now they think, I can practice separately. I don't need to practice in virtual reality. I can go out and practice going to a doctor's surgery in real life. So I think it's a really complex area to measure and to define which part of engagement is important. And I think sometimes usage and adherence and engagement are all confused, and engagement is a bit more than just using the digital intervention. It's also about engaging the effective components and also feeling motivated to want to go back and use it again and again.
Yeah. This is an interesting audience question thing. Sometimes as soon as we've even developed a digital intervention, it can be out of date. Or like how do we balance keeping the best evidence, the best technology, but doing the rigorous research and engagement that you've shown we have to do? Is there a way to have our cake and eat it too? Or to develop quickly, but to be rigorous so we're not out of date?
Yes, I think that's difficult. I think it's a challenge, but I think perhaps personalization, or having the option to for the intervention to adapt and to move according to the needs of the person or the evidence as it moves on. But that obviously requires more funding, more technical support, a more complex app to be able, or intervention to be able to respond to it.
Yeah. And certainly it's more complex, but I think compared to some of the biological research, it still is much more affordable and rapid. I think we have time for at least, this is an interesting comment or point saying novelty is undoubtedly a key factor in driving engagement with digital health interventions. For instance, one of your examples was virtual reality, VR, which stands out as a really powerful example of something novel for people, offering just this different experience. Do you think that novelty is going to be kind of one of our key driving factors of engagement, and that means we kind of have to keep ahead? Or is novelty kind of one part of a larger package?
I think it's one part of the pathway. I think it certainly affects your whether you initially engage and the early engagement, but the sustained engagement over time, I don't think can be driven just by novelty. And
Yeah.
I think it's interesting in the user-centered work where researchers talk a lot about not only consulting with participants about what they think they want, but also about what they need. So what results in behavioural change. Because you might think in your head, oh, I want it to look like this, but actually what you want is something that will result in you using it. So it is quite a complex field, but I think novelty is probably only part of the equation.
Yeah, and that's a nice guidance you gave people. It's kind of just initial engagement, getting in the door, using it the first time, as you showed us, that's necessary, but not sufficient. So I think with that, well, thank you, Dr. Smith, for sharing so much of just one portion of your work.